Hi, good afternoon. Welcome to another edition of Newton-Wellesley Medical Group Lunch and Learn on this glorious Thursday. Seems like we're getting a lot of nice weather days on Thursday. We're really excited to have Dr. Kavita Sitharaman back here again to talk to us this time about continuous glucose monitoring. Next slide, please. Thank you, Kavita. Just to tease the upcoming Lunch and Learns, we have a full schedule through June. We're excited to have Sean Rocket come in and talk to us about knee pain next week. The following week, we're going to have a talk about data integrity and the use of the medical record. We're excited about this kind of talk, stepping away from some of the real clinical stuff. And given where we are in today in delivering medicine, this is going to be a great talk. Following that, we're going to have a talk about carotid stenosis. And then at the end of the month, hey doc, the pain is in my back, not in my head. Alan Witkower is going to be talking to us. He's one of our behavioral psychologists and talking to us about back pain. As you know, all these talks are up on YouTube on just searching Newton-Wellesley Medical Group Lunch and Learn. They're also on our intranet with direct links to the talks. Feel free to kind of peruse any of those other old talks. Next slide. So we wanted to just remind folks about our spine center today, Newton-Wellesley Hospital Spine Center. The Spine Center has a multidisciplinary approach to relieve back and neck pain, and it's a great service for us as primary care docs. You can just refer the patient straight to that phone number if you're not sure if the patient needs to go straight to physical therapy or physical med and rehab or right to a surgeon or right to an injection. This is a great number to know, 243-5777. It's not as good as 964 GERD, but it's close, 243-5777. And patients can call, get an appointment very quickly, and we're working on very quick access in with a navigator, and then the navigator model. Of course, if you want them to see a specific doctor, they can also get them at that number. Next slide. And just to remind folks of our 5 physician wellness programs that are ongoing. You hear me talk about them weekly, our concierge program, where you can email them. They will give you suggestions of different services in the area, our virtual meditation classes, our Peloton 1-year free membership. We're now eclipsed over 100 people taking advantage of that program, and that will continue until the money runs out. That's a free year, no obligation for that. Our online coaching and physical training program and our virtual yoga class. Next slide. And just make sure people know about the 5th annual MGB Patient Experience Summit. It's happening actually next Thursday, and it'll be ending. There's a nice break in there, so you can watch most of the lunch and learn. And the summit topics with some with some breakout groups as well. So we're really excited about this talk. Next slide. And I'll let Kavita take over. Thanks, Kavita. You're on mute, so just unmute yourself and take over. Thanks.
Thank you, John. Before I get started, is the screen clear, or are you seeing a tab saying is the meeting being recorded?
It looks perfect.
Okay, thank you. Hi, everyone. I'm Kavita Sitharaman. I'm one of the endocrinologists at Newton-Wellesley Hospital. And at this juncture, it gives me a great pleasure in introducing our clinic and my colleagues and our support team to all of you. We are a group of enthusiastic endocrinologists, and we have focus in general endocrinology and also have our own areas of expertise and interest. Dr. Slovic is the chief of our department, and he specializes in osteoporosis management. Dr. Stepel-Resnick is the director of our diabetes division, and she manages several diabetes-related efforts at Newton-Wellesley Hospital. My areas of interest revolve around diabetes care in young adults, transplant diabetes, and diabetes care in the primary care setting. Dr. No specializes in neuroendocrinology, and Dr. Yasa is our thyroid expert, and she leads our thyroid nodule clinic initiatives. We are supported by a fabulous team of clinicians, nursing staff, and support team. And just very briefly about them, Elise Raymond is our nurse practitioner in the outpatient clinic, and most of our patients with diabetes will meet with Elise at some point in their journey. She is our diabetes technology expert and the go-to person to ask if you have any diabetes related questions. Our practice manager is Sandra McKay. Our nursing staff, we have an excellent team of nursing staff, Melinda Matthews and Ian Sim. We have a fabulous team of support members, Mike Fallon, our medical assistants, Heidi, Brittany, and our front desk latest addition, Jacqueline Flores. In the main campus, we have a diabetes clinic, as you all know, and this has several wings to it as well. And it is supported by an excellent team of clinicians, Kathy Casper, our certified diabetes educator, Lana Wiggle, who manages all of our inpatient consults and transition of care from inpatient to outpatient setting. Eileen Weiner is the nurse practitioner who helps with follow-ups of diabetes care. Kimberly Sabata is our nutritionist, and Lindsay Marin is our front desk staff. We are also available by e-consults. And in interest of time, I'm going to move into the topic of today, which is continuous glucose monitoring. It is a pleasure to be back on the Lunch and Learn series, and thank you for the opportunity. Some of the key take-home points from today's topic would include the following. CGM has transformed diabetes management. CGM devices have proven to improve safety and effectiveness of diabetes therapy, and CGM can definitely improve quality of life for those with diabetes. Let's take a brief look at how far we have come along with regard to sugar detection in someone with diabetes. Physicians have known about diabetes as early as 1500 BC, and it was in 600 BC that physicians realized that ants were attracted to the urine of patients with diabetes. And in the Middle Age, we used a practice called uroscopy, by which we analyzed urine to detect different diseases. One of the diseases that we consistently diagnosed was diabetes by this method. And between 1940s to 1960s, urine tests for detection of sugar became available for patients with diabetes. But the initial tests involved burning of urine on an alcohol burner and adding chemical reagent to observe the color change. And it was only in the 1960s that the urine color changing test strips were available for patients. Then between 1970s to until current date, the technology of blood glucose monitoring and digital blood glucose monitoring devices have become available for patients. Let's take a brief look at how a glucose test strip works. We all know about the glucose oxidase enzyme, which reacts with the molecule of glucose and converts it into gluconic acid and releases an electron. This electron generally reacts with water and oxygen and results in formation of hydrogen peroxide and reactivation of the enzyme glucose oxidase. What happens on a test strip is that this electron that is generated from this reaction is taken up by a mediator that transfers it to an electrode and generates current. And that current is read as glucose concentration. It was due to the availability of self-monitoring of blood glucose at home that we were able to perform various landmark studies such as the diabetes control and complications intervention and the epidemiology of diabetes intervention and complications study. And through these studies, we realized how important is glycemic control in preventing diabetes related complications. As you may recall, in the intervention groups, the intensive therapy subjects required to have blood glucose of between 70 to 120 milligram per deciliter for pre-meal as their target, and 2 hour postprandial was supposed to be less than 180 milligram per deciliter to achieve the targets for intensive group, and their therapy was optimized to achieve these goals. And what did we understand from these studies? That intensive therapy reduces diabetes related complications in various aspects. It also reduces the measures of atherosclerosis and over time reduces cardiovascular disease events. Intervention is most effective when we implement it earlier on during the course of diabetes. And the beneficial effects of intensive therapy persist for at least 10 years, even after the difference in the glycemia between the original intensive group and the conventional therapy group have disappeared. The concept of metabolic memory. But what are the problems associated with self-monitoring of blood glucose? As we all know, diabetes is a chronic medical condition, and requesting our patients to check blood sugar several times a day is definitely associated with increased disease burden because there is discomfort associated with testing, and we often have unrealistic expectations. We all know that diabetes is a dynamic disease, and therefore the time points when the patients check their blood sugars might be perfectly within goal, and they might miss testing at time points where the glycemic excursions are actually happening. It can be time consuming. The ease of testing is influenced by the environment in which the patient is testing. For instance, a student at school or a colleague at a workplace. And definitely cost is a barrier, and patients are often limited by the number of test strips they are provided because of the cost. And this influences how tightly they can have their glycemic control. What about hemoglobin A1c? On this slide, you have 3 different graphs, and all of these scenarios, patient has an A1c of 7%. But in the first graph, there is significant degree of hyperglycemia and hypoglycemia. In the second graph, there is some hyperglycemia and small amount of hypoglycemia. And in the third graph, most of the blood sugars 100% in range. And therefore, the A1c doesn't reflect the dynamic nature of diabetes and what the patient is actually undergoing and facing on a day-to-day basis living with diabetes. This led to the concept of development of continuous glucose monitoring, which provides interstitial glucose concentration measurements in an almost continuous and real-time fashion for several consecutive days, with insights on glycemic dynamics and trends through wearable, minimally invasive sensors, and they are equipped with visual and acoustic alarms for alerting patients for hypoglycemia and hyperglycemia. We have evolved significantly since the concept of Cgm was introduced over the last several years. The first Cgm was a glucose watch that involved irritation of the skin and measurement of interstitial glucose from the surface of the skin. And this subsequently evolved to Medtronic coming up with the first real-time Cgm in 2004. Subsequently, the Cgms were integrated with insulin pump, and these days we have various types of Cgm that we recommend for our patients, including the Dexcom, the Freestyle Libre, we have the Guardian sensors, and the Eversense, which is an implantable Cgm. So what happens when the patient applies a sensor on the skin surface? This is how the sensor probe looks. There is an electrode that is on the open surface of the microlumen of the needle, and the interstitial fluid is allowed to interact with this electrode to measure interstitial glucose. Let's take a look at different types of Cgm that we have today and a rough comparison of how they work. The mechanism of the first 3, that is the Dexcom, Libre, and Guardian, are all through glucose oxidase mechanism, and the Eversense uses fluorescent biosensors. The warm-up time varies between 1 to 3 hours for the first 3 and 24 hours for the Eversense Cgm. The transmitter lifespan is variable, and this often changes as there is upgrade in the Cgm. Dexcom might come up with G7, and the transmitter lifespan would definitely be different for that, for instance. And the site is typically on the arm or the abdomen. Mean absolute relative difference is the metric that we use to evaluate the accuracy of the Cgms, and they are all roughly comparable. Many of the Cgms are integrated with smartphone insulin pumps. Some require calibration with finger stick, and the sensor lifespan varies with each of these Cgms, and the implantable one is for 90 days. So what data do we have in support for use of Cgm? In the interest of time, I'm not going to go into the details of each of these studies. This is a nice article that looked into several Cgm studies and the impact of Cgm in someone who has type 1 diabetes. In addition to improvement in A1c, the significant change that the patients experienced was the time spent in hypoglycemia. So Cgm use in someone with type 1 diabetes can really be life-saving and prevent the percentage of time that they spend in hypoglycemia and prevent severe hypoglycemia. And this is a table that goes through several studies in patients who have type 2 diabetes and have worn Cgm intermittently, few days of the week, few weeks of the month, and on various stages of their pharmacotherapy. Some were not on any medications and some were on insulin. And basically, what data did we gather from all of these studies? Significant A1c reduction is noted in those who have higher A1c to start with when they start using Cgm compared to self-monitoring of blood glucose. Most of the benefit is seen in those who wear the Cgm most consistently. Cgm provides reduction in time spent in hypoglycemia, specifically in those who are at high risk for hypoglycemia. And Cgm use can result in improvement in diet, exercise activities, and weight, perhaps without intensification of pharmacologic intervention in type 2 diabetes, though we may need more data in support of this. And over the pandemic, we have all realized how beneficial CGM has been, and it definitely facilitates telehealth and improvement of glycemic control. So what do we look at when we see our patients with diabetes and who are using CGM in the clinic? We look at this profile called the ambulatory glucose profile. And there are several terminologies on this slide that you may want to become familiar with. The target range that is set for most of the patients is between 70 to 180 milligram per deciliter, and below 70 is hypoglycemia, and less than 54 is even worse. And we want our patients to spend at least 70% of the 24-hour time frame in target range. And we recommend that there is no hypoglycemia for sure, and if they have, to minimize the time spent in hypoglycemia. The other important aspect metric that we look at is the average glucose. The terminology that you may all be familiar with, it is called glucose management indicator. It's roughly an equivalent of hemoglobin A1c in the next 3 months. This is an average of blood glucose over the past 2 weeks. And glycemic variability is also an important aspect that we look into, because this is something that the patients are living with on a day-to-day basis, and it is measured as a factor of coefficient of variation, and the target for this should be less than 36%. This is a slide that shows the various recommendations that we provide for patients with type 1, type 2 diabetes, and the significant background they might be living with diabetes in. For someone who is elderly and or who has a history of severe hypoglycemia or at risk for hypoglycemia, you can see here that the time in range percentage has been changed to greater than 50% rather than 70%. And for time spent over 180 milligram per deciliter, it is less than 50% instead of less than 25%. And for the same reason, to prevent hypoglycemia, we recommend that less than 1% of the time be spent less than 70 milligram per deciliter. From the data that we have for CGM use in pregnancy so far, we have set the target rate between 63 to 140 milligram per deciliter. And therefore, any blood sugars, any interstitial glucose values less than 63 milligram per deciliter is considered hypoglycemia with CGM use. And greater than 140 is high, and we have suggested some percentage values for time spent in those ranges. This is a nice slide that compares 2 different studies where they looked into how time in range corresponds to A1c. And so this is an important metric that you may want to review with your patients when you see them in the clinic in follow-up after initiation of CGM. For a patient who has 90% of their time spent in range, you might expect that their A1c changes to 6% in the next 3-month follow-up of the measurement of hemoglobin A1c. What other information do we provide for our patients when they use CGM? We advise them to look at the arrow trends. The first arrow trend is with regard to Dexcom, and this is with regard to the Libre. And the arrow trends, if it is 2 arrow going up, it indicates that the blood glucose is rising very rapidly at a rate of greater than 3 milligram per deciliter per minute, or greater than 90 points in the next 30 minutes. And similarly, at the same rate, it is falling very rapidly. And how patients can use this data while adjusting their insulin dose is that if it is a pre-meal time, they can adjust the insulin dose to prevent hyperglycemia or hypoglycemia. And they can also use these arrow trends 2 to 4 hours postprandial to decide what they should be doing to keep their blood sugars or their interstitial glucose values in time and range. Let's take a look at some of our patients who have been benefited with CGM use. This is one of my patients who was diagnosed with type 1 diabetes and in diabetic ketoacidosis, managed by our fabulous inpatient team, started on basal bolus regimen and advised to test blood glucose by finger sticks 4 times a day. And this is a 19-year-old student who was a freshman in college during the pandemic. So there's a lot going on in this patient's life, and how beneficial CGM was is something that the patient appreciates every single day. But within few weeks of starting to use the CGM, the patient was able to bring the blood glucose values to close to perfection. But we should understand that this involves a lot of effort from the patient side and collaborative effort between the patient and the provider team and constant interaction almost on a day-to-day basis to achieve this goal. This is one of my patients who has type 1 diabetes and is on insulin pump. And as you can look here, the GMI is about 7.4%, and the time in range is not optimal. And the blood glucose values are all showing extreme degrees of glycemic excursions. Every day of the week, the patient seems to be having so much of variability. And what do you do in this situation is acknowledge and appreciate how much the patient is going through living with diabetes and try to empower them and lead them in the right path by providing appropriate support. The same patient in the next few months, you can see here that the GMI is 6.9%. Though the blood glucose values are not perfect here, there was one day where 100% of the time she was in range. And this is something that the patient really admired, and we also encouraged her to do her best in this path. This is one of our patients who has type 2 diabetes and began using Libre at the start before optimizing medical therapy. And you can see that the time in range was very low, and the patient realized how often the blood glucose values were high. And then we began optimizing medical therapy in addition to lifestyle modifications. We added SGLT2 inhibitors in this situation. And in the next few weeks, you can see that there were some episodes of hypoglycemia. And then what we did was to advise the patient to stop the oral sulfonylureas, which were probably contributing to the hypoglycemia. So it definitely helps with lifestyle modifications and also optimizing medical therapy. This is an elderly gentleman who is almost 90 plus years of age, and none of his blood sugars were in range at the start, but it made him understand that it would take time and effort from both sides, and also optimizing his medical therapy with start of a very small dose of basal insulin. And as you can see here in the recent weeks, the time in range has improved to 85% with no hypoglycemia. So I think that CGM is beneficial for every patient with diabetes and at different stages of their diabetes journey. That is at diagnosis, recovery phase from the glucose toxicity in specific populations, optimizing insulin dose and preventing glycemic excursions, and diet lifestyle modifications, weight management. Some of the CGM related concerns are adhesive sensitivity, site infection, CGM anxiety, that is constantly looking at the graph, and the constant awareness of the disease. Some do not like this, and it has to be appreciated by the provider team as well. The alarm fatigue, and a key point to educate the patients that the CGM measures interstitial glucose and the fingerstick glucose is blood glucose. And cost is definitely a concern in terms of coverage, although during the pandemic, we have had better results with the coverage benefits for some of our patient population. So how do we operate in our clinic? We as endocrinologists and our clinicians discuss with patients, and we initiate the CGM. We set goals for follow-up. Our fabulous nursing team help us a lot with regard to teaching the patients how to apply. They do their first application. They work effortlessly on prior authorization and getting CGMs approved for patients. Our medical assistants gather data and transport data back and forth between patients and the provider. Our front desk staff are very important in coordination of care and patient follow-up. We also get significant support from patients and from their family and significant others if patients are sharing data with the family members. And there is a constant communication between primary care team, patients, and endocrinologists to achieve proper glycemic control and help the patients and make them feel more empowered in their diabetes journey. So in conclusion, we can say that CGM is useful in preventing acute glycemic excursions. CGM devices improve safety and effectiveness of diabetes therapy. They are definitely helpful in preventing life-threatening hypoglycemia and improving quality of life. CGM use is effective in various populations with diabetes, and CGM improves effectiveness of telehealth that we have all realized during the pandemic. So I had to really abbreviate this talk. There's a lot to learn about CGM, and I hope this was helpful to some extent. Thank you for the opportunity.
Vita, thanks so much for that great quick talk. There's one question here in the chat box, and then I had a quick question before that. So one of the things I find as a PCP is I wonder about the accuracy compared to the finger sticks when it comes to the CGM. If they're running low, do you tell your patients to do a finger stick on top of that, or you can pretty much be certain, or that's right on time with that?
I think that is a very good discussion, and we all have this discussion with our patients. If the patient is asymptomatic and the CGM is reading a low interstitial glucose value, then for the first few times, I recommend my patient to test by finger stick to see what their glucose value is. As we all know, interstitial glucose lags a little bit behind compared to that of the blood glucose. And so perhaps the blood glucose would have been in that value, but the patient did not pick up, as early as the interstitial glucose values might depict. So in the first few days of use of CGM, it is something that the patient needs to understand, and it's a learning curve. And if they are not symptomatic and the finger stick glucose readings are over 80 milligram per deciliter, then we don't recommend treating for hypoglycemia. But for the most part, when patients are symptomatic and the CGM values are low, then it is very important to go ahead and treat for hypoglycemia. Perhaps some of my colleagues on the screen might be able to share their experiences as well.
I can talk for a moment about that, John. So one thing we found with the Libre in particular is that if the sensor is not a good sensor, it tends to run low. And so I do warn patients of that. In fact, there is a little icon that shows up on the reader or on their phone. If they're having rapid changes in the glucose, it's an indication that they do need to double check a finger stick. And so there's another sort of phenomenon that can occur called compression hypoglycemia, which happens overnight. So if you're lying on the sensor that's on your arm, it can read low. So it's important to talk with the patients, as Kavita was saying, and correlate symptoms with the number. It's not just a blind reaction. You need to think about it, and if it doesn't make sense, double check with a finger stick.
That makes sense. Thanks, Jean. There's a question here from Dr. Finn. Are there any studies comparing optimal lifestyle with optimal medication interventions?
As I indicated in this table here, let me just go back. There have been very few studies that have actually looked into CGM in patients who are new to diagnosis of type 2 diabetes and those who have been on hypoglycemic therapy. And I think in those very few studies, where even in those with pre-diabetes, CGM has a significant impact in perhaps lowering A1c by 1%, weight loss of 7.2 kilograms, decreased carb intake. So I think it can have significant benefit, but we need more data in terms of how much of an impact they can have.
Right, and I guess I think, I know Lenny's on the call, but I guess he would say that it's not really patient-oriented outcomes yet, so we'll have to see about that. What Dr. Phillips wanted your comment about, it seems like some people are buying CGMs online, even people without diabetes. Is there any value, or is this just crazy talk?
I think CGM is a device like blood pressure monitoring device, and anyone who is interested in their well-being and wants to understand how their glucose metabolism is handled by their body is welcome to use CGM as long as they are able to afford it. So I feel personally that it is a very valuable device.
Spoken like a true diabetologist, I guess, I would say about that. So I don't see any other, I think there was one other question. Oh yeah, so Lenny, Dr. Finn also was asking about this, and a lot of us think about this. A lot of us now, our patients are turning on to the CGM, and you follow a lot of our patients, obviously, and Elise and Gina and team, but a lot of them come in with these numbers, and a lot of us still, we don't really know how to manage the CGM. Are you doing e-consults, or what's the best way to kind of contact your team or to get, is there a primer that you'd suggest for the PCPs to try to help figure out how to use the data? We all know how to use A1Cs and fasting glucose because that's ingrained in our DNA, but this new data and how to manage that. I don't know if you have any comments about that.
I think it is a fantastic point, and how we collaborate with the primary care team in the future with regard to CGM data and sharing. In our clinic, we have a cloud for each of the CGM, and whenever we want to help the patient, we go into that system and look at the progress that the patient has made. But similarly, we should be able to find a path. E-consults, I think, is a great path to communicate with regard to CGM. Perhaps Dr. Steppel-Resnick might have more thoughts on this, and we are looking forward to mutual ideas from the primary care team as well.
I think at this point, using our nurse practitioners that are based at the hospital, they're fully adept at helping with that. So that's probably the fastest route. If you need other than an e-consult. E-consult is by far the fastest route. But if they're interested in getting a little more guidance on their CGM and working closely with somebody for a little bit of time, then that would be a good option. And then obviously an endocrine consult if it looks like it's going to be a long-term kind of relationship that they're looking for.
Great, thanks. And we're coming near the hour. One of the frustrations I've seen a lot is, how do you get the data from the websites that are all commercial into Epic smoothly? Are you guys working out these? I'm assuming at some point this is going to be worked out. That must be a frustration to your team way more than it is of the primary care team.
Right, and I think the lot of hard work and credit goes to our team effort, and we get fabulous support from our nursing staff, our medical assistants, front desk staff. And helping patients with CGM involves day and night effort. So I would say that most of the effort comes from teamwork. It is not integrated fully with Epic, so we use a lot of cut and paste and snipping efforts when we document these on the chart. Yeah.
Yeah. Okay. So we're still at the cut and paste snip stage. All right. I appreciate it.
Although I will say that Jeff Phillips and I have talked regularly about that. So hopefully there will be progress over probably years, but to make it a little bit more seamless to get that data into Epic.
Great. So we'll just blame it on Jeff. Make sure he'll he's taking his mic off now.
Listen. I don't think you're gonna have to wait years. This is kind of one of the new digital health MGB efforts, is patient-generated health data, and CGM is a big part of it. So more to come, I think, within the year, but I tend to be too optimistic. We'll see.
Thanks, Dr. Phillips. On that note, thanks again, Dr. Sitharaman, for coming. I hope everyone has a wonderful Memorial Day. Hopefully the weather will turn around on all of us, and each day will look like today looks. We'll see you next week to talk about knee pain in the primary care setting. Thanks for everyone, and thanks again for the talk. Bye.
Thank you.